So let's go to the next slide. So first of all, this is one of my favorite Hirschsprung's pictures. This is the world record of projectile for enterocolitis. If anyone wants to challenge this picture, please send it to me. It's a tiny baby on the left, and I think we got about 6 or 7 feet. So you know what is brewing in that colon, of course, with bacterial overgrowth in that child. But let's talk about now the patient has had their pull-through already, and they develop enterocolitis. The pull-through was done at 1 week of age, and the child is now 1 year. Okay? And I've intentionally made this difficult on you. So the patient had a newborn pull-through. It's a year out, and the patient has enterocolitis. What would you do? Let's
Mark,
go to
their stooling pattern between those two times has been what?
They've been doing well.
Normal.
And then the sudden episode of enterocolitis. So let's see what the audience thinks, and then we'll go to one of the Megans. The Megan without the H. Okay, so let's see what everyone thought in 1 second. There we go. All right, look at that. Well, what do you think?
We were just discussing neither of us have an H in our name. But despite that,
Are you serious?
I think
Are you both Megan? Oh, I am so sorry.
we shouldn't have sat next to each other. But I think Casey's point is a good one. If this is a single bout of enterocolitis, that's a different child than one with multiple bouts of enterocolitis and an obstructive stooling pattern. I think when you're looking at a kid with an obstructive stooling pattern with multiple bouts of enterocolitis, you're thinking about all of the above. You're trying to find why is this child getting recurrent bouts of enterocolitis, and it's up to you to prove that there's not a transition zone pull-through, there's not something anatomic, and then you can try Botox, because we know all of these kids have non-relaxing sphincters, and sometimes I've seen good success in the kid that doesn't have something anatomic with a trial of Botox.
Jack?
Yeah, I think if this is an isolated episode of enterocolitis in a child who's previously done extremely well, I probably would just treat the enterocolitis and send them home and hope that maybe it was just a viral illness that precipitated it and he's going to be fine. But I think in a child who's had recurrent bouts of enterocolitis or one severe bout, then I follow the algorithm, and we've actually, the APSA Hirschsprung's disease interest group has published an algorithm to try and work through this. And it would involve ruling out a mechanical obstruction, and the contrast enema and a rectal exam will do that. And then you want to do a rectal biopsy to make sure it's not a transition zone pull-through or aganglionic. And while I have the child asleep to do that, I would do an injection of Botox, because most of the time the biopsy comes back normal. So you can avoid an extra anesthetic by just doing the Botox and seeing how they respond to it.
Just 2 clarifications. What is your threshold for doing all of this? A second episode, third episode? Does the age matter? Just repeat that.
So it's interesting that many of the children with enterocolitis don't develop it until later on. And there's also overlap between the child who has enterocolitis and the child who just has ongoing obstructive symptoms. And sometimes they don't really present that way until they transition from breast milk to solid food. Often they're over a year old. So I think you have to individualize. With enterocolitis, as I said, if one episode I think I'd allow a child to have. I think if they have 2 or 3 that come as a recurrent problem, then you go down that path.
And then your technique for Botox?
I always put them to sleep. I don't use ultrasound guidance because I don't think it's necessary, although some people do. I use a 27 gauge needle. I take 100 units and put it in 1 cc, and then I do 8 injections circumferentially at the dentate line, going in a couple of millimeters in each injection to try and get the sphincter.
Very good. All right, let's go to the next slide.